Hello, my name is Ashwini. I'm honored to speak on behalf of our task force as we work to advance pediatric cancer research. 17,000 people younger than 21 are diagnosed with cancer annually. Despite this, pediatric cancer research receives only a fraction of the time, funding, and innovation compared to adult cancer research. Let's start by looking at the differences between pediatric cancers and adult cancers, review the historical milestones, explain differences in funding allocated towards pediatric and adult cancer research, and analyze how these funding gaps affect innovation and long-term outcomes for patients. Finally, I'll propose a community-based plan to help bridge the gap in innovation and funding for patients. Cancer is a disease in which some of the body cells grow uncontrollably and spread to other parts of the body. Despite this broad definition, there are key differences between pediatric and adult onset of cancer, because the biology of a child is different from that of an adult in some ways. Well, what are some of the key differences? Pediatric cancers come from mutations in genes that affect normal cell development, while adult cancers come from mutations that affect cellular process genes. To evade cell death, cancer cells in children activate embryonic development processes, while cancer cells in adults deactivate self-destruction processes. And the metastasis aspect is also different. The point is, there are fundamental differences between pediatric and adult cancers. Thus, separate and specific research is needed to understand and successfully treat pediatric cancers. And pediatric cancer care has evolved tremendously over the past century. In 1971, the National Cancer Institute was created by legislation President Franklin D. Roosevelt signed. In 1947, Dr. Farber founded the first chemotherapy research program for children with cancer, and this became the model standard for most pediatric and even adult cancers today. In 1971, President Richard Nixon signed the National Cancer Act, which allows the NCI director to establish cancer research programs and centers. In 1973, clinical trials for children with acute lymphoblastic leukemia led to current cure rates of about 85 to 90%. In 2021, treating advanced Hodgkin lymphoma with brentuximab vedotin limited the long-term health outcomes associated with chemotherapy drugs like vincristine. In 2025, a CAR T-cell therapy was able to shrink tumors in pediatric patients with an aggressive brain and spinal cord cancer known as diffuse midline glioma. The positive impact of research can be seen today. In the US, the 5-year survival rate for all pediatric cancer patients has risen from 63 to 87% from 1970s to the 2021. The mortality rate has decreased by 67% from 1970 to 2023. And some cancers, like Hodgkin lymphoma and retinoblastoma, have a survival rate of over 90%, while deadlier cancers have a survival rate of under 25%. Despite all this innovation, there are still disparities due to ethnic, racial, geographic, and socioeconomic populations. Hispanic children have the highest incidence in the US, while non-Hispanic Black children are 30% more likely than non-Hispanic white children to die from certain pediatric cancers. And underserved rural areas also have similar disparities, partly due to limited access. According to the National Cancer Institute, the definition of a rare cancer is a cancer that occurs in fewer than 15 out of 100,000 people annually in the United States. And all pediatric cancers fall into the rare cancer category, and some cancers occur even less than the ratio, making it harder for researchers to obtain research funding. By clumping all of these cancers together in the same category, it hides the true incidence and mortality rates, making it harder to determine what to prioritize and where resources should be allocated. Regarding funding cuts, there's a 25% cut to the U.S. Department of Health and Human Services, a 38 to 40% cut to the National Institutes of Health, a 37% cut to the National Cancer Institute, and federal government spending for pediatric cancer care is only 4% of the total cancer budget to begin with. With these funding cuts, the amount of money allocated towards pediatric cancer patients is decreasing even more. Because pediatric cancers are so rare, pharmaceutical companies and the government provide limited funding. The pediatric oncology market is relatively small, and companies do not want to invest in such a small market with limited financial gain. Because of the NIH funding cuts, it threatens pediatric cancer trials, causing delays and maybe full cancellations of projects. For example, programs were dedicated to studying the effects of immunotherapy in neuroblastoma and gliomas, two of the most deadliest pediatric cancers. But because of these funding cuts, these programs have been cut down or eliminated across the country. This is not a good policy that not only halts research, but all the work that has been done goes to waste. And many standard treatments for pediatric cancers were approved before the mid-1980s. Currently, there's a 6.5-year lag in the cancer treatment trials for children compared to adult cancers, which is a major disparity. And 95% of survivors face significant health-related issues because of a lack of funding directed towards pediatric cancer patients. So, our team has come up with recommendations regarding community-based solutions to help guide our plan to advance pediatric cancer research. National level lobbying is important since lawmakers may not understand the true toll of pediatric patients' cancer and its outcomes. Direct lobbying involves directly talking to government officials who is involved in formulating legislation. We would ask them to support, co-sponsor, or vote a certain way on a bill that is beneficial in terms of pediatric research. Grassroots lobbying includes encouraging the community to contact the government, and we'll tell them to sign letters to bring more awareness about the seriousness of pediatric cancers. Such collective efforts can lead to meaningful policy changes. Senator Bob Hall is from the Texas Senate, and Representative Angie Chen Button are key people that we are contacting to start our plan of action. Fundraising is an excellent way to drive more awareness and gain funds from the community to gain support. We'll also be hosting a local fundraising cancer awareness event, including making social media flyers, etc. We'll convince and encourage corporations and philanthropists to contribute by having targeted presentations to convey the urgency and the problems with pediatric research. This is not an exhaustive list, but these are some of the corporations that support pediatric oncology research. And our team has established contact with some of these corporations as part of our plan to gain more research funds. We also must use cutting-edge technologies such as AI to expedite research at a much lower cost due to limited funding, resources, and support. It's important to have alternate ways that we can advance pediatric research even without reaching our fund goal. By implementing AI, we could become one of the pioneers to integrate AI and pediatric research. Pediatric cancer pathology is fundamentally different from that of an adult, so we need to reclassify cancers to specifically identify the deadly and rare cancers. Pediatric cancer care only receives 4% of the total budget, so we need to redirect the NCI and NIH funding towards pediatric cancer care. Lobbying can also help raise more funds and pass legislation that incentivizes pharmaceutical companies, including tax breaks, to develop pediatric cancer drugs and create additional fellowship grants for the pediatric oncology training. Community awareness events can also have a significant impact in shaping policies, including removing disparities due to racial, ethnic, geographic, and socioeconomic factors. Targeted presentations and getting contributions for corporations and philanthropists can also help with funding. An integrated use of AI can accelerate the discovery of medicines and increase collaborative research between hospitals, academic centers, and NIH. Without significant funding and financial investment, advancements in early detection, diagnosis, treatment, and cancer survivorship among children is going to become stagnant or worse. Implementing this plan would set us apart as innovative leaders in healthcare, reflecting the hospital's philosophy of relentless pursuit of excellence. It is up to us today to invest our resources to help the young ones who are the future. Thank you.